We have no relevant financial interest. And this talk will actually overlap a little bit on the other talks in this section, since we're talking about imaging of the cornea and the eye. And in terms of cataract surgery imaging, you have to think about the whole eye. So cornea is a big part of it, but I'm going to focus a little bit more on the other parts of the eye, since I think we're going to have wonderful lectures about the cornea. And I promise not to talk about form fruste. And I said it. Okay, so beyond IOL calculation. So in terms of imaging for the eye for cataract surgery, we want to make sure that we're doing all the imaging necessary to make sure we have the right power of the IOL. That is really the number one goal. But we also want to make sure that the eye is healthy. So let me focus a little bit on that. So in terms of considerations, what guides us on what imaging we should do, it's really to look at the patient themselves as an individual. So do they have a history of something in their eyes? So do they have corneal surgery? Do they have dry eyes? Do they have retinal issues, glaucoma issues? And those are really what guides you in terms of what imaging you need. Of course, this is about IOL choice, and now that we do have a selection of, besides monofocals, we have torics, we have multifocals, extended depth of focus, then we have to think about the whole eye before we can make the proper choice. And then, of course, in terms of the density of the lens, one of the newer modalities really is the Artemis Arc scan, and this is courtesy of Dan Reinstein. And I think that using high-resolution digital ultrasound to look at the lens, for example, you can actually tell in a posterior polar cataract, for example, you can image the back of the lens, which is very helpful. You can also do proper sizing of the sulcus or of the iris, the anterior chamber, the bag. And again, those are things that will help us hopefully pick the right power. If in the future we have actually different powers of different sizes, and we can actually select which one is right for that eye. Astigmatism is a big focus when we talk about pre-op imaging for cataracts. And of course, we're going to look at the cornea. So again, I'm not going to belabor this point because you're going to hear a lot of talks about the cornea and the astigmatism, but we use a lot of different ways. Topography is always a good one to look at the front of the eye in order to know what the anterior surface of the cornea will be when we talk about toric lenses. But tomography, as you just heard, is really important to look at the inside of the cornea as well and the back of the cornea. This is important when you're trying to figure out whether the astigmatism is regular or irregular. It also gives you an idea whether the eye is dry. So the imaging will tell you whether the measurement that they took was accurate or maybe it was inaccurate because of other factors like anterior surface disease and dryness. In terms of looking at higher order aberrations, there are machines that we use in order to look to see how regular or irregular the cornea is. One of the common ones that's used is the NIDAC OPD3. I have no financial interest in this. And what I like about this machine is that it gives us more than just a topography machine. It gives us a lot about angle alpha, as well as the pupil measurements, and then it also gives us a nice picture of the mire. So here's a typical screen, and this is courtesy of Maya Bowen from Marco. And if you look, she's circled which ones you look at in this particular NIDAC OPD3 screenshot. And this is a way to look to see if you're thinking about a multifocal lens or extended depth of focus lens. You want to look at a variety of factors. So number one, look at the image on the bottom right. You're looking at the placido rings for the overall quality of the placido ring. So is the eye dry? Do you see a lot of dropout? Are the mires regular? Number two, you want to check the angle alpha. And in a multifocal lens, if you're centering on the pupil, it's one of the factors that you have to consider. I always recommend that you're always centering the center of your lens on the visual axis, so hopefully it's not as big of a factor, but it is just another factor to keep in mind. Number three is a corneal astigmatism. That way you know whether you're putting in a astigmatic or a astigmatism correcting lens or not. Number four is the amount of higher order aberration. So this is one of the machines that allows you to decipher out the overall higher order aberration versus a corneal aberration. And here you're really looking at coma and trefoil. So you want to make sure that it's approximately less than 0.33 or 0.32 is really kind of the number that we throw around. And then looking at pupil sizes, again, different types of lenses out there have different ways in which they correct near and distance, so the pupil size can become a factor in the type of lens that you choose. Ocular surface disease, this field has really exploded over the last 10 years. Now we can really analyze not just if their eyes are dry, we can really look at the meibomian glands. You can actually look to see the tear breakup time, the quality, the tear lake measurements. And so a lot more can be done with the anterior surface. And I think, again, it's one of the newer ways that we can really analyze to see whether this patient is a good candidate for a presbyopia correcting lens. Retinal imaging, I do think, is something that we should all do more than we probably do as cataract surgeons. Oftentimes we just rely on our clinical exam, and sometimes if the cataract is dense, it's really hard to see the macula. So I think that doing a macular OCT preoperatively is very, very useful. I actually do it in all patients rather than just in specific cases or specific lenses. And I have found that, I have picked up a lot of pathology that I did not know was there. One of the key ones is the traction on the macula. So you cannot see that on clinical exam. And if there's traction and you operate on that patient and the patient ends up with a macular hole, then it's good to know ahead of time that that was a risk. Looking at the eye, besides just the macula, if you can't see through the eye, then oftentimes we use an A scan. Immersion A scan is always best. And then in terms of the B scan, to look for any other pathologies. If there's a vitreous hemorrhage, you can't see through it. If there's a tumor, any other issues, then the B scan is very important. Now, cataract and glaucoma, the fields have really overlapped, and a lot of the cataract surgeons are doing MIGS procedures. So making sure that you're doing imaging before you do a MIGS procedure to look at the visual field exam. And then, of course, the cornea is very important when you're worried about cataract surgery. So specular microscopy, I think, is also a great way to evaluate the cornea. So in summary, I think that pre-op imaging is a very vast field. It's increasing every year. And I think it's always important to think just beyond the non-contact biometry to look for the IOL power. Think about all the different parts of the eye that you should investigate to make sure you have an excellent outcome. Thank you very much.